Okay. And now I'm going to...
The topic for today is the hemodynamic management of the neurologic patient. And I'm more going to focus on subarachnoid hemorrhage as this is really our newest technology or our newest type of admission that we'll be having to Vassar Brothers Hospital or Medical Center. So the goals of this lecture, I believe that one of the other speakers will discuss the physiology of the cerebrovascular system, but I'll discuss really the specifics for hemodynamic management, and then differentiate the common presentations, and then discuss the basic management strategies. So physiology of the cerebrovascular system. The neurons are dependent on blood flow. They're highly dependent upon blood flow. The brain has a high metabolic requirement and little ability to store metabolic precursors and relies on glucose and oxygen, specifically from the blood supply or the blood flow, to provide those precursors. So cerebral blood flow, the absolute minimum that the brain needs is 50 mils per minute per 100 grams of tissue. And that supplies glucose and oxygen to the system. It has its protective mechanism, as this is a relatively small amount of blood flow that's necessary. There's collateral blood flow. The anterior circulation provides about 70%, posterior 30%. We have the bridging circulation through the circle of Willis, and then autoregulation, where the local sites are able to vasoconstrict, vasodilate, and thus increase or decrease the supply based on need. The cerebral perfusion pressure. I'll go through and define some of these words and abbreviations that I'll be using throughout the discussion. But the CPP is the perfusion pressure across the brain, and this is the major determining factor of cerebral blood flow. And the mean arterial pressure and the intracranial pressure are the two main factors that determine the cerebral perfusion pressure. So your CPP equals your MAP minus your intracranial pressure. The way that the brain becomes injured is essentially lack of nutrients, specifically oxygen and glucose, which leads to, which can be from nutritional factors, tumor, infection, trauma, metabolic disorders, and infection, which leads to ischemia and infarction, and especially impaired autoregulation. Then this leads to reperfusion injuries with the influx of white cells, which impedes blood flow, causes free radicals formation and cytokine production, which leads to cell destruction, vasoconstriction, edema, and then damage to the penumbra. And the penumbra is essentially the relatively normal tissue that surrounds areas where there's been damage, and that's where we get our secondary damage from these brain injuries. So injury occurs when the cerebral blood flow is less than 50 mils per minute per 100 grams of tissue. You get slowed EKG. Once you get even less, then you get loss of electrical activity. Then 10 to 15 mils ATP is maintained, and then less than 10 mils per minute per 100 grams of tissue, you get loss of ATP. And ATP is the primary source of energy within the cells of the body. And without ATP, you get cell loss and cell death. The brain is able to function with a reduced oxygen extraction fraction, but as this oxygenation and glucose declines, the brain continues to have irreversible changes to the cells. And then another concept that's important for the understanding the cerebrovascular system is the Monro-Kellie Doctrine. Essentially, all the tissue, brain, blood, cerebral spinal fluid is incompressible within the cranial vault. and there is a finite volume within the cranial vault. Blood is 10%, CSF is 10%, and brain is 80%. Any increase, even minute increases, in the volume dramatically increases the pressure, thus decreasing the cerebral blood flow. So cerebral blood flow is very critical to the maintenance of healthy brain tissue. And here's a nice graphical representation of the cerebral blood flow, and specifically the Monro-Kellie Doctrine. As you have your intracranial pressure, or the pressure within the brain vault itself, and then you have the volume, you get progressively, you reach this critical mass of volume, and you get a critical increase in the intracranial pressure. And from this point on, this is quite critical. And this is where you start to get compression of the brain tissue, cell death, and irreversible changes to the brain. Then looking more towards blood pressure and mean arterial pressure, so this is your cerebral blood flow, 0, 50, 100, and this is your mean arterial pressure. So in normotensive patients, you begin to get ischemia once your mean arterial pressure drops below 50, well, somewhat below 50, and then your cerebral blood flow starts to decline here. In hypertensive patients, this may be different, and they may require a higher mean arterial pressure in order to maintain that cerebral blood flow. Then at the higher degrees of blood pressure, higher blood pressure, 150 to 200, then you again start getting this increased cerebral blood flow and more of a hyperemia state, where again you're surpassing the volume abilities of the cranial blood flow, or sorry, of the cerebral blood flow, and of the mass that is allowed within the cranial vault itself. But I think what's important about this graph is to show the difference between normotensive patients and hypertensive patients. And it implies that there is a relatively broad area, but comparatively different areas for the maintenance of normal blood pressure, normal cerebral blood flow at these mean arterial pressures. So this is a very busy graph, but what's probably most important is here, mean arterial pressure. This is the pressure within the brain, or pressure in general. So for here, this is the mean arterial pressure, and then again the cerebral blood flow. And it's essentially the same graph, but it shows how differently these pressures interact with each other. So here you can see the mean arterial pressure. There's a plateau between mean arterial pressure of 50 to about 150. Essentially, those are the normal range. And that's where we have relatively preserved cerebral blood flow. Then, looking at your intracranial pressure between 0 to about 40, you have preserved cerebral blood flow. And then as this intracranial pressure increases, you get a significant decline in your cerebral blood flow. So your intracranial pressure and your mean arterial pressures are very important for the maintenance of your cerebral blood flow, and why we obsessively follow them, particularly in patients with subarachnoid hemorrhage. So the different presentations. This is where it's most confusing to medical staff. How do we treat these different patients? Theoretically, or at least to an observer, anytime you have a stroke, we should treat these the same. But there are actually radically different treatment strategies for patients, depending on the type of presentation, the timing of the presentation, the management that's done for the patient, and also the patient's factors themselves. So just to go a little bit into the different types of presentations. So how do we diagnose? First, we start out with a patient presenting to the emergency department, to the primary care provider, or to ambulance with complaint. Physical examination is done, and it's determined that this person likely has some type of stroke, whether it be hemorrhagic, embolic, or thrombosis. Patients are usually taken to emergency departments and have an emergent scan, a CT of the brain without contrast, and then the next step would be CT angiography. MRI if available, and then for the small percentage of CVAs that cannot be diagnosed, or hemorrhagic CVAs that cannot be diagnosed by CT or MRI, then lumbar puncture would be the next step. Rowley and his group in 2001 developed a very nice, simple system for classifying and the management of acute stroke radiologically, and I've just kind of taken that and applied it to general practice. So the 4 Ps of acute stroke. Parenchyma exactly tells us what type of stroke it is, or what does the parenchyma look like. Type, what blood vessels are involved. Perfusion, how has the perfusion generally been affected by the stroke. And then penumbra, again, this is the tissue, the essentially normal tissue that's now ischemic as a result of the primary site of the injury. So ischemia versus hemorrhage, types, large arteries or veins involved, perfusion, collaterals, and net circulation to the brain, and then penumbra, the brain tissue that is ischemic but not infarcted, that's surrounding the primary injury. So parenchyma. Ischemia is usually 80% of patients who present with stroke, it's an ischemic stroke. Thrombosis of a primary blood vessel or embolism from a distant site versus hemorrhage, which is about 20%, subarachnoid, which will be our newer presentation that we'll be taking to VBMCs. Epidural, subdural, usually as a result of trauma, and then intraparenchymal, which can be trauma or hypertension induced. So management strategies. The key concepts, though this is kind of out of the scope of this presentation, but it's always important, before we start diagnosing a stroke, we need to make sure that we stabilize our patient and make sure that the patient is well managed. So always check airway, breathing, circulation, disability. Some patients may need emergent intubations prior to management. They may need central line access, other issues before we're able to take them for intervention, and addressing these concerns first and foremost will give you the best outcomes for your patients. So airway, breathing, circulation, and for some, circulation even will proceed airway management if the patient presents needing CPR. So ischemic stroke. You have the ischemic core of the stroke, and then the penumbra, which is the tissue surrounding. And there's essentially 2 stages of presentation. There's initially an autoregulatory vasodilation. Stage 2 is reduced cerebral blood flow and increased oxygen extraction fraction. And many of our patients will present usually in the reduced cerebral blood flow stage. 60 to 80% present with hypertension on presentation. I've seen diastolics or systolics up to 280, or the diastolic in excess of 150 to almost 200. So treating this acute presentation becomes one of the primary factors that we deal with in these patients, or the primary goals for management in these patients. It's clear that the extremes of blood pressure range have higher mortality and morbidity. There's a very large trial, the ISAC trial that was done, or ISAT trial, which showed that patients who presented with embolic strokes had much higher mortality, morbidity, with very high blood pressure, systolics in excess of 180, and then those patients with systolics less than 140, or really 130, they had relatively similar morbidity and mortality. So through this study and through general consensus statement, we've determined that keeping the blood pressure somewhere between 140 and 180 in these acute hypertensive presentations is much more advantageous for your patients and less likely to have secondary consequences such as further ischemia, further bleeding, or transformation from a embolic to hemorrhagic, or other consequences. So hypertension guidelines are predominantly followed the AHA guidelines. Again, this is a consensus statement rather than a randomized double-blinded control trial, and really are based on thrombolysis, post-thrombolysis management. So blood pressure, systolic less than 140 or 185, and diastolic less than 110, and you want a 15% reduction in the first 24 hours. Once you get to that 24-hour mark, then the recommendation is that then you aim to reduce the blood pressure to what we consider as a standard of systolic of 135. But this is also really based on patient to patient. There may be some patients that you get them down to 130 and you notice that within 48 hours of their stroke, you notice that their urine output drops off or they become more symptomatic. Those patients, you would try to increase their blood pressure and try to keep them what you have observed as their physiologic blood pressure, rather than trying to force everybody into this 130 to 150 range. So you definitely want to avoid hypotension. Those patients have a significantly higher risk of secondary stroke and hypoperfusion. But there really is limited data how low we should truly get them. So based on the current guidelines, we try to get them 130 to 150 and then look at the patient's clinical symptoms. If it declines below the demonstrated threshold, if the patient's not symptomatic, then you let it be. But if they are symptomatic, then you do try to increase the blood pressure. How do you go about doing it? Vasopressors. It's really unclear which specific drug you should use. Most studies have shown that dopamine has an increased risk of cardiac arrhythmias, but other than that, there really are no true guidelines. So whatever medication you think would be of benefit to the patients, that's what's recommended. The Elias trial demonstrated the safety of albumin in acute ischemic stroke, and this is specifically giving patients fluid bolus, fluid resuscitation in order to maintain the mean arterial pressure. They did actually in this study show to a very small degree that albumin may have an actual protective effect in these patients, where they matched mean arterial pressures to the control subjects and found better mortality and morbidity in the patients who were treated with albumin versus patients who are not, all other factors being equal. But I think that that's really not likely to be something that's prime time. It's a very expensive intervention and questionable benefits in one study. So to increase your blood pressure, vasopressors, fluid bolusing, and albumin is perfectly safe. Some of the neuroscientists that I've worked with, neurointerventionists, neurosurgeons, love albumin and advocate it for everybody, including the staff, but I think conservative use of it would be appropriate. So ischemic stroke, embolic, atrial fibrillation, big controversy about whether or not we should anticoagulate these patients. Most people determine the size of the stroke. If it's a relatively small focal area of infarction, then they would advocate for anticoagulation. But if you do have a very large area of stroke and penumbra, it's possible to convert an ischemic stroke to a hemorrhagic stroke. So again, it's really based on the patient's presentation. Rhythm control, again, it's based on the patient's presentation. If it's an acute onset of atrial fibrillation, then rhythm control would be appropriate. But if it's more of a chronic presentation, then rate control, most of the studies have supported. So hemorrhagic stroke, subarachnoid hemorrhage, this is where we have probably the biggest controversy with regard to hemodynamic management. Subarachnoid hemorrhage, it depends on the patient presentation. If it's an unsecured AVM or a patient who was incidentally found to have an AVM of significant size, management is one way. An unsecured AVM post-subarachnoid hemorrhage has a different management, and then secured AVM post-subarachnoid hemorrhage, again, very different management strategies. So subarachnoid hemorrhage, 85% are barianeurysms. They present with acute hydrocephaly, risk of early rebleeding, cerebral vasospasm as a late consequence, parenchymal hematoma, seizures, and medical complications. The medical complications that we worry about would be neurodeficits, hepatic dysfunction, respiratory failure, pneumonia, ARDS, acute pulmonary edema. They can have Takotsubo's cardiomyopathy, where they have essentially cardiogenic shock, or acute renal dysfunction. So all of these factors will play in how you're going to manage these patients, and that's what really makes it very complicated and difficult to classify or standardize our management for these patients. So subarachnoid hemorrhage, unsecured AVM, definitive management is the goal. Endovascular versus neurosurgical, and you maintain their normal blood pressure. If the patient presents and they're normally hypertensive, your goal isn't to acutely try to reduce their blood pressure, it's just controlling them in their normal until they can have definitive management. Subarachnoid hemorrhage, when you have an unsecured AVM post-subarachnoid hemorrhage, your goal is definitive management within 24 hours. So these patients aren't typically being rushed to endovascular procedures where they're having coiling or clipping within 5 hours. These patients will be going to surgery. If they present in the morning, they may go for the procedure the next day or later on that evening. So these patients are usually admitted to ICU and then managed relatively aggressively for the first 24 hours within very small parameters. But again, you have to keep in mind that they may have neurogenic pulmonary edema, they may have some coagulopathy, and you have to work with the individual patients. But you do want to avoid the extremes of blood pressure management. Subarachnoid hemorrhage, once the AVM or the aneurysm is secured, then our primary goal is prevention of vasospasm. Not that everything else falls by the wayside, but vasospasm is this kind of dark cloud looming over the patient's management the entire time they are in the hospital. And vasospasm can occur from 7 to 21 days post-subarachnoid hemorrhage. So for 7 to 21 days, we are just aggressively monitoring, examining, evaluating, and looking for vasospasm in these patients. So vasospasm, what is it? I don't think we really know what it is. It's very complex etiology. It's likely that the blood clots that are sitting within the brain are releasing multiple factors that cause impaired autoregulation and balance between endothelial messengers, there's neuronal cell death, free radical liberation, and usually the management is transcranial Dopplers done by ultrasound technician that specifically belongs to the neurointerventional team or a specific individual who's identified in the or specific ultrasound tech who's identified as the one person to do the TCDs because there is so much variability between users. But each day the patients will have pretty much from admission transcranial Dopplers looking at the MCA velocities, and they map them day to day to see exactly where they're going, and we monitor to see are the TCDs going up, and do we need to do some prophylactic management on top of the management that we're doing, or do they need to go for an additional definitive procedure. So 4 to 21 days post-bleed. So vasospasm prevention, the cornerstone of therapy is nimodipine, which in the U.S. is an oral medication. There's IV formulation, but it hasn't done very well in the U.S. Triple H therapy, and then there's a few novel therapies. Essentially, we can't fully agree on the recommendations. There were two major studies, one in Europe and one in the U.S., that just asked intensivists, neurointensivists, neurosurgeons, and neurointerventionalists, what do you do with your subarachnoid hemorrhage patients? How do you manage them? And they were just all over the board. Some groups stick to the very strict Triple H therapy, whereas others stick to let's not make the patients hypervolemic, keep them euvolemic. It's variable. So the recommendations are, there are no recommendations. This is, Triple H therapy is essentially based on therapy from studies from the 70s and 80s, and multiple studies validating and invalidating Triple H therapy have been released since that time, and there just doesn't seem to be a clear consensus or a clear path for us to take. But in the majority of hospitals where I've worked in, we have done some degree of Triple H therapy. What is Triple H therapy? So it's hypertension, hemodilution, and hypervolemia. And I can remember being a fellow when we first started doing it at our hospital. We had a lot of patients with hypertension, hemodilution, and hypervolemia, and almost immediately they were all intubated. Half of them were in acute pulmonary edema. Most of them were in the unit for 3 weeks plus, and everything was a mess. Then progressively we started to pull back from these recommendations and weren't as aggressive. But hypertension, the goal is to maintain your mean arterial pressure greater than 100. And this is specifically after you've secured the aneurysm. You cannot do this if you have an unsecured aneurysm. So you maintain your mean arterial pressure greater than 100. You hemodilute, which is actually very easy to do in ICU as we phlebotomize our patients throughout their stay. And to find an ICU patient with a hematocrit greater than 30 is just a rarity. So there are no clear recommendations on how to get your patient hemodiluted. And then hypervolemia. Hypervolemia means different things to different people. In some groups, as long as the CVP is greater than 25, they're happy, which is huge and can drive probably the majority of patients into flash pulmonary edema. And these patients are actually quite vulnerable because they already have a neurogenic pulmonary edema or already in cardiogenic shock from their subarachnoid hemorrhage. So hypervolemia has really been probably the most discussed and the most debated management strategy of Triple H therapy. The most recent neurointensive care unit that I've worked in, our goal was to keep the patient euvolemic, and our total input for IV fluids, oral fluids, intakes, everything, had to be greater than 3 liters. And our goal was to avoid hypovolemia. So we would match the urine output. If the patient put out 100 mils per hour, we gave them 100 mils plus whatever to keep them at greater than 3 liters input per day. But again, sometimes we're not able to do this if the patient's in frank pulmonary edema, they're intubated, we have them on high levels of PEEP, and we can't oxygenate them, then something has to give. So HHH therapy, endovascular management of vasospasm. You can't get much more aggressive with your HHH therapy, but keeping your blood pressure or your MAP greater than 100. Endovascular management, whether that be through angioplasty, vasodilator therapy with preservine, milrinone, or calcium channel blockers would be the management. Just to briefly go into hemorrhagic stroke, because as subarachnoid hemorrhages start to come, then everyone else starts to come to your medical center. For trauma, the goal is to maintain a normal blood pressure, avoid hypertension, hypotension, and then definitive therapy to evacuate the hematoma if it's indicated. So to go back and discuss the different types of interventions that we have so that we can maintain our goals or to somehow meet our goals for the management of patients, antihypertensive therapy. Our ideal agent, really our ideal agent for any type of aggressive blood pressure management would be short-acting, easily titratable, metabolized independent of organ function, and has a positive effect on the cerebrovascular bed. There really is no such agent. So we basically look at the patient, look at their individual presentation, and then adjust our medications to what we need. I think a good example would be a patient who presents in frank cardiogenic shock, yet their blood pressure is relatively high. Then you would not throw a beta blocker at this patient or labetalol at this patient because you would have a negative effect on the cardiovascular function or the cardiac function. So in those patients, you might use a calcium channel blocker, something that has more focal effect on the vasculature rather than having an effect on the heart. So ACE inhibitors, wonderful medication, but as soon as the patient develops renal insufficiency, everyone runs for the hills. But it is an excellent vasodilator, can have some anti-inflammatory effects, and has local effects in the vascular bed, particularly or potentially in the cerebral vascular bed. But again, with renal insufficiency, those are a no-go. Beta blockers, again, very good medications. Esmolol is a drug that's very easily titrated, but if you have a patient with some degree of cardiomyopathy from their subarachnoid hemorrhage, may not be the ideal medication. Calcium channel blockers really are likely the mainstay for these patients, in particular nimodipine, nicardipine, as they're easily titrated. Nimodipine has specific central vascular effects, and it's probably the best studied calcium channel blocker in subarachnoid hemorrhage. Nicardipine, again, is a very good medication, very short-acting. It works predominantly in the peripheral vascular bed and specifically arteriolar vasodilation, making it probably the more ideal calcium channel blocker for the management of subarachnoid, but again, that's just my opinion. Then hydralazine has some effects, but not everybody is a fan of hydralazine because of some of its side effects. And then nitrates. Nitrates I would consider lower on my go-to medications list because it is a general vasodilator. It's a venodilator and an arteriolar vasodilator. So in patients who have some degree of cardiomyopathy, starting with a nitrate will decrease their preload, decrease their cardiac outputs, and thus handicap your cerebral blood flow. So I would say nitrates would be on the bottom of my list of medications for use. Hypertensive therapy, as I said before, there really are no superior vasopressors in the management of subarachnoid hemorrhage. Vasopressors that seem to be a favorite, phenylephrine, probably because you don't need a central line for its use, and it's very popular with anesthesiology. Norepinephrine has general alpha and beta activity and can provide you a little bit of inotropy in addition to, or increased cardiac output, in addition to peripheral vascular vasoconstriction. Fluid resuscitation, again, there really is no consensus for which fluid is best. There is growing data that normal saline is, as one of my prior professors would call it, the drug of the devil, where it can cause a moderate metabolic acidosis and lead to increased morbidity, mortality in some small studies. So the ideal fluid, I would say, at this point would be lactated ringers, Plasma-Lyte, which is probably about $20 a bag, and then albumin, which again is about $230 to $350 a bag. So lactated ringers, I think, is ideal. But again, looking at the individual patient's characteristics and what fluid you're going to use would determine that. There's increasing data for the use of hypertonic fluid. It's relatively small volume that you give. It easily crosses the blood-brain barrier. It has some anti-inflammatory effects, can increase and augment cardiac output. And this is probably going to be our future with the management of subarachnoid hemorrhage and avoiding fluid overload with this higher free water fluid resuscitation. But still, the jury is out on that. So in summary, for ischemic CVAs, our goal is to reduce the blood pressure progressively, avoid the extremes of blood pressure in the first 24 hours, and then for subarachnoid hemorrhage, it's really, the primary goal is definitive therapy and determining which patients are candidates for coiling or interventional procedure versus clipping, neurosurgical procedure. And then post-therapy, how are we going to manage these patients? Through triple H therapy, vasopressors, IV fluid resuscitation, and close monitoring and management. I think I might have whizzed right through that. So any questions?
What is your experience
So the question is regarding the newer oral anticoagulation, which I have such a difficult time pronouncing them, but Xarelto in particular, it's a nightmare. They are a nightmare. When the drugs first came out, I think it was probably within a month of their initiation. I was working and living in Australia at the time. Within a month of them being approved, we had severe subarachnoid intracranial hemorrhages that we just weren't able to control. One of the major drugs that we did use, and we also use in subarachnoid in general, would be prothrombin X or prothrombin factor, which is essentially a cryoprecipitate of 2, 5, 7, 9, and 11, which for some odd reason we don't have available just yet at Vassar Brothers. But we found the best outcomes with those patients. And then we just pour FFP and cryo into them and say a prayer. But it has been a nightmare with those medications. It'll end in 12 hours, is what they say, but But if your brain is full of blood, and as you saw with the Monro-Kellie Doctrine, it really doesn't take a large amount of blood to increase your intracranial pressures in excess of 50. Any other questions? That's a very good question. So the question is, how is intracranial pressure measured? There's multiple devices for monitoring the intracranial pressure. There are intraparenchymal devices. I'm struggling to remember the name of them, but there's intraparenchymal where they basically do a borehole through the skull and then attach a small device to the cerebrum, or to the brain. There are the ventricular systems where a drain is essentially placed into the brain itself, or into the ventricle of the brain, and you can drain fluid and you can also monitor. I would say post-subarachnoid hemorrhage, that's probably the most common. And then there are other devices that look at they're dialysis devices, essentially, that look at the jugular venous oxygenation, glucose. It can also look at the lactate. And then from that, they can extrapolate what the ICP is. I think once we start doing subarachnoid hemorrhage management more aggressively and more commonly, we will likely have these devices that are being marched into the ICU likely. And then we'll have to learn how to manage those, won't we? Any other questions? All right. So, do you have questions? So before the AVM is secured, I should mention that it's very rare to have a patient present with an unsecured aneurysm. Probably what most commonly happens is the patient has a subarachnoid hemorrhage, you do the angiography, and you find that there are several other aneurysms that are present. Or a family member presents and then other family members have a screening CT angiography and it's found that way. It's very rare, unfortunately, to diagnose these. But pre-secured subarachnoid, AVM without subarachnoid hemorrhage, your goal is to maintain normalcy. For patients, if they present and they're floridly hypertensive and asymptomatic, then those patients will be more likely to try to progressively reduce their blood pressure over several days prior to management, rather than trying to acutely control their blood pressure. But with the hemorrhage, before they are secured, your goal is to keep their blood pressure usually less than 180 is the goal. Because the higher the blood pressure, the more blood, and the more blood, the more clots, the more risk of cerebral vasospasm, and then also more clot, more compression. So you do want to maintain, you do want to minimize the blood pressure, but as soon as it gets secured, then your management shifts, and it can be very difficult for some of the staff because 1 second you're trying to push, they disappear for 2 hours and they come back and you say, oh, okay, now we have to get their max above 100. You can have that dynamic shift within hours. But it really is the individual patient. You can have some patients who you try to get them to 180 and suddenly they're more symptomatic and you're trying to decide, are they more symptomatic because they're bleeding or are they more symptomatic because I've lowered the blood pressure? So you do have to use a little bit of caution and look at the individual patient, which is why I haven't made a general statement, this is what you must do, because every patient is different. Unfortunately, we still have to examine them. You have a question? So the question is the devices to measure the ICP, are they put in at the bedside or in the OR? It really depends on the neurosurgeon and the unit. Some units are set up so that they can do bedside intraparenchymal monitors. It's basically a Codman catheter, that's what it's called, which is a small catheter it's just a small burr hole, and then they slide it in and attach it to the parenchyma. And that can be done at the bedside. I would imagine, though, being in the earlier stages of such a procedure, most of ours would be done in the OR. And then the EVDs, or the extraventricular drains, those most likely would be put in the OR. But again, I've seen them done at bedside emergence. Oh, questions? So your question is, in the emergency department, should you essentially be giving starting LR or starting saline? I think the data is out there that we should really be using lactated ringers, especially for large volume resuscitation. I don't think it would do any harm giving 1 or 2 liters of normal saline. But once you start getting up to 6 liters, 7 liters, 8 liters, which some of these patients you may get up to that, depending on the bed situation, you do have to take that into account. So lactated ringers, plasma-lite is another one, but it's much more expensive fluid, would be the way to go. I can't imagine that it would become a part of the protocol because, again, it's so difficult to aggressively make protocols for these types of patients that I would imagine that it would be learn about it, understand the pathophysiology, understand why you're doing these interventions, and then base it on the patient. Well, so the follow-up question is, so the sodium, is that leading to the hypertensive crisis? Is that your question? Well, not necessarily. Sodium, I think of sodium more as a reflection of free water deficit or free water overload. Some patients can be hypernatremic, but it's actually more that they have a free water loss or a free water deficit. And in those patients, you would actually try to get give them as much free water as possible to improve cerebral blood flow, because as they become hypovolemic, then you start getting sludging within the cerebral blood vessels, and that can be a problem. So high sodium, think of it more as a free water problem, and those patients need more free water. In order to get your sodium up to cause high blood pressure, you would have to basically get like a big salt lick and spend the day licking it, which for some people might be nice, but it does take quite a bit of sodium to push someone to the point where they're having a hypertensive crisis from salt. Tom? So the question is, nimodipine and nicardipine, can they be used together? There are quite a few patients that we do end up using multiple medications. You can use them as nimotep or nimodipine, sorry. It has more CNS effects. It does have some arteriolar vasodilation effects also, but nicardipine is very pure arteriolar vasodilator in the periphery. What I actually find is more often when we have the patients on the nimodipine, they're actually hypotensive, and we're chasing the nimodipine with norepinephrine or phenylephrine, because they can become actually quite hypotensive, especially patients who have cardiogenic shock from their subarachnoid. So yes, you can use them together. Any other questions? I saw some other hands going. Everybody ready for lunch? Okay. All right. Here's a picture of my previous home. Thank you, Dr. Rothkamp.